Good morning, good afternoon, good evening, everyone. We'll give another minute or so and then we will get started. Thank you. Okay, everyone, it's 2 after the hour, so let's go ahead and get started today. Hi, everyone. Good morning, good afternoon, good evening. Thank you all very much for joining us today for the third session of Momentum's webinar series, Strengthening Analysis and Use of Routine Health Facility Data for Maternal, Newborn, Child, and Adolescent Health. We're really excited to have you joining us today and welcome you to introduce yourselves in the chat. My name is Emily Stammer. I am a Senior Research Monitoring and Evaluation Advisor with Momentum Knowledge Accelerator, and I'm really happy to be here with you all today. Before we dig into today's subject matter on data triangulation and analysis, I just want to go over a few housekeeping items in order to provide everyone with the best experience possible on today's webinar. Next slide. First, note that today's webinar and all other sessions during this series will be recorded and posted to the Momentum website. So if you're not able to attend all of the sessions for this series, you will be able to access the recordings and materials shortly after sessions take place. During today's session, some of the presenters will speak in English and others in French. We have simultaneous interpretation available for all sessions in the series. And I'd like to invite you to take a moment now to locate the interpretation icon at the bottom of your screen and select the audio channel that you would like to listen into for today's presentation. If you stay in this main channel, you'll hear the presenter speaking directly in the original language. About 1/3 of today's session will be in French and 2/3 in English. So on a related note, the slides that will be presented on the screen today will appear in the language in which the presenters are speaking. My colleague Zach will share links in the chat to the English-only and French-only versions of the slides so you can follow along with the presentation. We'll aim to give some verbal cues to note when to progress to the next slide. And then lastly, there will be a single break for questions and answers during today's session after all the presentations are complete. Please click on the Q&A icon at the bottom of the screen to submit any questions that you may have. We'll do our best to respond to questions either directly in the Q&A box or during our Q&A break. And then with that and with housekeeping out of the way, I think we are ready to begin. Next slide. Oh, there we go. Thank you. So the purpose of this series is to introduce participants to resources and tools that you can use to strengthen the analysis and use of routine health facility data for maternal, newborn, child, and adolescent health programs in your work with country stakeholders. Routine health facility data is an important source of information for decision makers to understand service utilization and service quality so that they can identify problems and make evidence-based decisions on policies and resource allocation. In an effort to strengthen the analysis and use of health facility data for MNCAH programs, the World Health Organization developed a guidance document and an accompanying resource package to be used for capacity strengthening in workshop and webinar settings such as this one. So the guidance document describes a catalog of indicators for MNCAH that can be monitored through routine health information system data. It also provides guidance on analyses and visualizations for the indicators. The document also, or the package also includes considerations for program managers for interpreting and using the data for decision-making purposes. the Momentum Knowledge Accelerator project has adapted those materials for this Training of Trainers webinar series. So during the series, we'll dive into the different components of the WHO toolkit to show participants how to access and use the resources. My colleague Zach will share a link in the chat where you can access the guidance document and accompanying resources. There's also a link in the slides that you'll be able to use to access the webpage. During this webinar series, you'll also hear about other practical examples from Momentum projects to help illustrate how the concepts covered during the series can be put into practice. And we'll highlight some existing resources, including tools and templates that may be helpful to support your work. So just a note, while some of our colleagues from the Momentum Awards were involved in reviewing some of the materials presented today, and we can answer questions about the subject matter itself, we personally were not best placed to answer questions about why certain content may have been included in the toolkit or excluded. For those questions or others, I invite you to reach out to the WHO using an email address that we can provide to you. Let's see, maybe Zach can put it in the chat. Just a note, I have actually reached out and asked questions before, and they are very responsive. So let's go. Next slide. During today's webinar, we'll be looking at components of the 4th and 5th modules of the toolkit, which cover data triangulation and analysis. We'll cover data interpretation and use in our session next week. And we will discuss data visualization in a sort of bonus session that will take place on September 26th. So stay tuned for that. Next slide. Just a reminder that each session in this webinar series has a similar structure and includes the same core components. We begin by introducing participants to key concepts related to the session's topics and highlight different tools and resources that are available to support your work in these areas. We focus largely on the WHO toolkit, but as I said, we'll highlight other key resources at the end of the first presentation. We'll then hear presentations from staff from different Momentum Awards and other external groups on how they've put these key concepts into their work and suggestions or lessons learned that they can share with you. Today's session, as I noted, focuses on data triangulation and analysis. If you missed the first two sessions, the first session covered an introduction to health facility data with a focus on MNCAH indicators. And the second session focused on data quality considerations when working with MNCAH data. And these presentations and recordings in both English and French can be accessed on the page dedicated to this webinar series on the Momentum website. Next slide. So today's presenters include myself, Adriana Almagnana, who is a Senior Technical Advisor for Immunization at JSI, and Jean Dorville, a Data Manager with Momentum Routine Immunization Transformation and Equity, joining us from Haiti. Next slide. So I'd like to talk a little bit about the objectives for today's session. Today, we're hoping to provide an overview of data triangulation and analysis and key points to keep in mind when supporting your partners working with routine MNCAH data. We'll highlight tools and resources that can assist with supporting partners to triangulate and analyze routine data. And then we'll hear from Adriana Almagnana about her experience triangulating immunization data in Ethiopia and the tool they developed as part of the UIFHS project. And then we'll hear from MRHIS with John about their work supporting analysis of routine immunization data in Haiti. Next slide. So now I'd like to dive in and provide an overview on today's topics, which include data triangulation and analysis. So many of you are probably very familiar with data triangulation, so I won't spend too much time on the background here. But when supporting local partners and country teams, this background on triangulation is important to cover, just to give your teams a good idea of what it is and why it's important. The process of triangulating data is essentially just synthesizing existing data from two or more sources to help address questions for program planning and decision-making. Triangulating data from different sources is important for a number of reasons. Triangulation helps us corroborate findings, confirming or challenging our initial set of findings based on a single source. Triangulation can also help maximize a data source's strengths or make up for any weaknesses it may have. For example, if one data source is broad yet lacks detail in certain areas and another is detailed but lacks the breadth, you can use the two together to tell a more holistic story and make up for each source's weaknesses and leverage its strengths. Additionally, triangulation can also help provide a clearer picture for evidence-based decision-making. Looking at, say, immunization coverage combined with conflict data may help tell the story that conflict affects immunization uptake, or that perhaps by triangulating supply data with coverage data, you can see a relationship between the two and can help inform policy and programming. Next slide. So in terms of MNCAH programming, what can we use data triangulation to do? We can use triangulated data to do the same things we do with regular single source data to begin with, like looking at the current performance of the health system and identifying gaps, or just to evaluate the impact of programs on MNCAH outcomes. But the addition of different sources allows us to gain a better understanding of the context in which programming is taking place. For example, weather or crop yield data could be triangulated with child health nutrition data to examine trends and better understand the context. Or by triangulating health facility data with survey data, you could better understand barriers to, say, antenatal care, uptake, or delivery in facilities. Additionally, triangulation can improve confidence in your findings and promote rigor. Checking your findings and trends with one source against another can help validate your findings. If you find that, say, with one source, ANC coverage in your population over the time period is rising, and then you look at another source for the same population and same time period, and it indicates that your coverage is declining, you know that there's likely a problem with one or both of the sources, and it really forces you to investigate more. Alternatively, if coverage is similarly rising in both your sources, you can feel better that the trend may be accurate. Finally, reviewing data from different sources enhances the capacity for critical thinking, data analysis, and use of data by encouraging review and use of diverse sources. So by looking across multiple sources, you're getting a better idea of the context and taking a critical look at this bigger picture, which honestly can only be helpful for better understanding a situation or context. So we'll get into this more in a future slide, but I'm interested and curious about what secondary sources you all may have pulled MNCAH data from in the past. If you want to put those in the chat. What sources have you used most commonly, and what are some of the rarer sources that you've used? I'm interested to see. I have pictures here on the slide depicting household surveys, supply chain data, weather data, and conflict data. I have to admit, I've only used the conflict data once, but have probably used household surveys, like I see some are saying the demographic and health survey, to triangulate with health facility data the most. Yeah, I think DHS is the biggest source that I've used as well. Great. Oh, and the SPA, yes. Next slide. So how can we support our teams to triangulate data? As with any analysis approach, you want to encourage your teams to sit down and plan it out first. Make sure that your teams, your partners work through a planning cycle. The cycle presented in the WHO toolkit has 4 steps that include asking the key question, identifying existing data sources, summarizing data and local context in order to make sense of the data, and then it ends with developing an action plan. So we'll get into these 4 steps in the next slides. Next slide. So to start, we'll identify key program problems and related questions. And I know from experience, it's tempting to dive right into data collection. And I've definitely done that before, but it's so important to sit down with your teams and really think through the process and make a plan. We include this as step 1 to triangulation, but honestly, this would be a step that you'd want to do no matter what, right? Before you start collecting or analyzing data. You'll want to work with the in-country partners you're supporting to ensure that the scope of the analysis has been well defined. You want to sit and think through how you plan to use the data to answer the questions. Is it to inform local program planning, or is it to inform larger policies and regulations? And an important point here is making sure the questions are answerable and actionable. As with any analysis, you don't want to get to the end and have a lot of data that you've collected and analyzed that don't fit together and can't tell a story. That's not a fun place to be in. And again, from personal experience, it's important to map this all out from the beginning as much as possible. Then, as always, you want to engage your local teams and stakeholders. Make sure the question that you're asking is truly actionable and useful in the setting. You want to engage a variety of relevant stakeholders from the beginning, reviewing examples, brainstorm, facilitate group discussion. The WHO guide suggests that good criteria for identifying a data triangulation question include that the question is important, answerable, actionable, appropriate, and feasible. The next step then will be to identify your data sources. And here's another place where I just think it's really important to talk to your stakeholders. Stakeholders can often provide a great overview of what data sources are available and regularly used and help explain the differences between them and identify strengths and weaknesses. But don't forget to also speak with stakeholders outside the MNCAH realm. There are often so many sources of data that we don't even think about when we're coming from the health perspective. A lot of times from budget or finance, logistics. So when identifying sources, just encourage your teams to try to identify all relevant sources, get an idea of how easy they are to access and to be compiled, and think through the strengths and weaknesses of each source, and consider documenting your list of sources for the future. And this is important. If you have ever stumbled across a list of secondary data sources that exist for a given population or time period, it's like finding a unicorn, like winning the lottery while holding a 4-leaf clover on top of a pot of gold. So basically all the symbols of extraordinary luck in my culture put together. These lists are so helpful to other researchers and programmers, but even for yourself and for your teams to reference back to if you need. And while these lists that you make and catalogs of secondary sources, they're not current for very long as new data sources always pop up, they are at the very least just a really good starting point for anyone. Next slide. So at this point, it's helpful to encourage your teams to think through the kind of data they want to use, or more specifically, what they want to use it for. Are you trying to provide context around your health facility data? If so, you probably want to consider diverse types of data like we discussed before. Your conflict or your weather data, budget data, or data collected, some data from household surveys. For example, you could look at malaria incidents in the facility and also pair that with BedNet ownership data from a household survey. If you want to support specific findings from routine health data, you may want to consider more similar data, particularly if it's collected using a different methodology. That independence is useful for assessing and addressing limitations of different data sources. For example, If you wanted to look at trends in diarrhea incidents over a given time, you could look at number of cases in a facility and compare that to reported cases of care seeking for diarrhea from a series of household surveys like the DHS. You have to be careful because the source of the numbers is different and they represent different things. One is self-report of seeking care, another one is, clinical diagnosis of things. But if you are trying to get an idea of generally of trends over time, you could pair these and look at them. Since we're talking about being careful, it's also really important to make sure the data you're triangulating represent the same time period and geography as much as possible. Similar time periods and geographies are always ideal, but if you're triangulating data for things that are seasonal, like diarrhea or malaria, it's even more important so that you're comparing apples to apples, as we say. Next slide. So then to round out the 4 steps, you want to next summarize the data and the local context and encourage your teams to do so. You can do this by assessing the data quality. You want to check for completeness of a data source and internal consistency, evaluate trends across data sources, the place and time, and incorporate context and local knowledge. Your local teams are the ones who can tell you about that nursing strike that closed facilities for a month or other contextual factors. Use the findings to brainstorm multiple hypotheses to explain your findings, and then be very, very honest about data limitations. And I think a lot of people stumble here because they think documenting all the limitations will make people question their data or results. And at least from my experience, I can tell you the opposite is true. When I don't see limitations, I question the data more. All data is faulty. There's almost always missing data or errors or something. So when I see a good long list of limitations, I know someone has really thought through the possible shortfalls and biases and has acknowledged the effect that they could have. So then you want to develop an action plan for disseminating your information. Sit down with your comms people around the table and work to generate simple key messages for your target audience. You want to tell a story with your data using visualizations and make sure there's a logical flow to the story. Case studies are a nice way to do this. And then put forth actionable recommendations based on your triangulation results. And don't forget to validate them with your stakeholders. Can you advance one, Dakota? Good, thank you. They know the context better than anyone, and they can tell you if what you're recommending is feasible or what you should prioritize. Next slide. Et voila, you have triangulated with your team. Congratulations. The WHO guidance also provides a few more slides on tips and tricks that you may want to check out, as well as this table of MNCAH program issues that could be improved with triangulation. Estimates of target populations is a big issue. We've been looking at that with immunization coverage and trying to triangulate all sorts of different estimates from different sources. But also looking at MNCAH program performance and impact of external events on MNCAH service delivery. I mentioned nursing strikes earlier, but obviously, COVID-19 is another disruption associated with changes in service delivery, and working with triangulated data can help explore those as well. So in summary, triangulation is an important tool and approach in data analysis, and one that may come as second nature to many of us. But I think thinking through it and actively planning out your question and purpose for triangulation can really help reduce the amount of unnecessary data collection and analysis that you do, and help ensure that you're working toward answering your question. Next slide. So with that, I want to shift briefly to discuss supporting data analysis with your partners and teams. Just to note, of all of the topics in this WHO toolkit in this series, we'll probably give this one the least attention, and we'll focus mostly on the planning side of things with analysis. But if you're looking for more, I really encourage you to refer back to the WHO toolkit and some of the other resources we'll discuss in a few minutes. Our presenter, Jean, also covers analysis of routine immunization data in his presentation. Next slide. So, what do you think of when you hear the word analysis? I know I think of statistics and complex equations and the like, but what is it really? And most simply, it's the process of transforming raw, unprocessed numbers or measurement or even text, known as data, into information, which is organized, processed, and structured. And that transformation process gets us one step closer to the ideal outcome of evidence-informed decision-making. Next slide. Next slide. Thanks. So you see in this slide a number of key public health measurement concepts that are presented in the WHO toolkit and guide. Causation, association, correlation, as well as statistical terms and concepts like ratio, rate, proportion. All of these are likely terms you're familiar with, and when supporting teams with analysis of routine data, it's important to know not just what these terms represent, but to think through how they can and should be used and what form of analysis is most appropriate for your data. And the best way to step back and think through what is most appropriate for your data is to make a plan for your data analysis. Next slide. So how do you support teams to plan for data analysis? How do you get your teams around a table, smiling like this, working on a plan? Well, first, I would recommend bringing chocolate. That's tip number one. But then I'd recommend talking through a few steps with them because planning makes everybody smile. So first, make sure everyone is on the same page about why you want to analyze the data. Why is it required? What question do you need to answer? Who is the target audience for the analysis? And once you align, work with them to outline a data analysis plan. Next, you want to review available data and indicators to identify and understand the indicators of interest for the analysis. The purpose of your analysis is important in identifying which MNCAH indicators you will use. Make sure everyone on the team understands the indicators. Make sure they understand what exactly is being measured, what the numerators are, what the denominators are for calculating the indicators, and what their data sources are, and even what format they're in. If you plan to make comparisons or assess progress over time, you want to, where you can, identify targets or baseline values where you can. And then identify the denominator data and its source. And, if you have to, you have to estimate where needed. Then finally, step 3, prepare data and plan for analysis. Make sure you take a very intentional pause here. It's hard. Everyone wants to dive in, but taking the time here will save you time later. Look at the information you collected in step 2 and review it holistically together. Look at those quality issues and discuss them. Think through how you might mitigate or address those quality issues. Then you want to download, organize, and consolidate your data. If you didn't already take a close look at the format of your data in step 2, now is the time to do that. Make sure it's in a format you can work with, and if it's feasible to conduct the type of analysis you're planning. Then take a closer look at the data quality. And this is such an important step, particularly with facility data. I think in almost every presentation in this series, you'll hear presenters talk about data quality as a challenge. Take this time to review and adjust data quality where needed and document any adjustments you make in the original data set. You also want to make sure that you keep the original unadjusted data as well, so you can always just look back and see how they're different if you need to. So then you've set yourself up to begin analysis. And again, not going to go into that in greater depth, but the toolkit goes into a bit more detail. And it covers things like equity analyses, and that kind of thing. But we won't have time to cover that in today's session. So I really urge you to refer back to the toolkit for more information on that. Next slide. So before we head into the exciting presentations, I want to take a few moments to highlight some of the resources that are available on triangulation and analysis that may be useful in your work supporting these efforts. A few of these are immunization specific, but if you have other examples of good resources, particularly those available in French or other languages, please feel free to share them in the chat. Be interested to see. Next slide. Oh, here, we're here. Nope, you're good, go back. Sorry, Dakota. As noted earlier, triangulation and analysis are covered in modules 4 and 5 of the WHO toolkit, where much of the content from today's presentation was sourced. So you can always review that material. Next slide. The toolkit is really nice. It includes useful exercises that can be used with teams to work through concepts like triangulation and analysis of MNCAH data. There's a nice facilitator's guide that helps you to guide teams through some of these exercises. Next slide. Then, in terms of triangulation, there are a few useful resources I wanted to highlight. One is a brief on triangulation of immunization data that outlines different immunization tools used at the health facility and how they can be used together. It's a very simple, short document, but it really does a nice job, I think, of presenting the concept of triangulation in a succinct visual manner. And it's also available in languages other than English, which I hate to say is hard to find. You can find it in Spanish, French, and Portuguese. Next slide. Adriana will also talk about this next resource in her presentation, but through the UIFHS project, JSI developed a Microsoft Excel-based immunization data triangulation tool with 5 regional health bureaus in Ethiopia. The tool triangulates immunization service statistics from DHIS2 with supply chain data from the Logistics Management Information System to produce ratios that can reveal data quality issues such as overreporting or programmatic issues such as consistent understocking of vaccine and supplies. The materials are available as supplements to an article published in Global Health Science and Practice that describes in more detail how the tool was developed and used, and some of the findings from the key informant interviews that aim to understand the feasibility, benefits, and challenges of using the tool. So all of these resources are available, but I do want to note, given the emphasis that we put on context for triangulation earlier, that this tool was developed with the Ethiopian context in mind, so would need to be heavily adapted to use elsewhere. Next slide. The next resource is a more general training toolkit that USAID and Measure Evaluation put out a while back. It is not MNCAH specific and it's a bit dated, but for basic analyses, things don't change too much over time. So the current WHO toolkit draws from this resource, so you'll find some of the content repeated, but this measure toolkit also includes job aids that you could use with your partners to help support basic analysis. It also has a lot of hands-on exercises too, in case you're looking for that, but it's only available in English, which is too bad. So if you have good resources, like I said, particularly those that are available in other languages, do share, and perhaps we could add them to the annex of this slide set when it goes up on the website. Be nice. And with that, we conclude the first presentation on the background material. I'd like to now hand things over to my colleague, Adriana Almañana, who is a Senior Technical Officer for Immunization at JSI, to talk about her project's experience working on data triangulation for immunization in Ethiopia. Adriana?
Thanks, Emily. And thanks to everyone for joining this session today. Today, I'll be talking about an experience that we had on a JSI project in Ethiopia to establish a data triangulation process comparing immunization program data and supply chain data. And we'll talk also about some important implementation lessons as well. Next slide. Great. So just a little bit of background first on kind of our whole process. Um, Next slide. So in Ethiopia, the ministry's expanded program on immunization, or EPI program, um, they have administrative immunization program data that's typically reported in DHIS2. There's also a mobile-based system called Embrana that was being used as a logistics management system, and this recorded immunization supply chain data and was managed by the National Pharmaceutical Agency. So overall, what we were seeing was that there were some persistent challenges with timeliness, with completeness, with quality of immunization data, as well as just overall performance of the routine immunization program. We also were seeing, related to the data, that these data were being reported through different systems, through different departments, and the coordination and data sharing between those departments was limited. So all of that basically meant that what we were seeing was that immunization program staff, particularly at the subnational level, did not they were not always able to look at or use supply chain data in their decision making processes, and that the review and the use of data overall towards program improvement was not always consistent. So these were kind of some of the challenges and the context that we wanted to try and tackle. Next slide. So what we did was hold a consultative workshop with different stakeholders to discuss. And really what came out of that was an agreement that there was a need to develop a regular process for triangulating data. So what we did was come up with just a short list of indicators that the group wanted to be regularly tracking, um, and in order to make it feasible and be able to kind of look at performance and analyze on a regular basis. So once they had kind of chosen their few indicators, we also worked to develop the interpretation of those indicators and to come up with suggested actions depending on that data. So just to kind of look at the example here of what really we're talking about. One example is, if you had the doses administered plus all of your stock on hand for the previous 3 months, and you compare that to how many doses had been issued, over time, those numbers should basically be equal. And if they're not, if, for example, the ratio is higher than 1, then you know that this is going to indicate some kind of data quality issue or perhaps over-reporting of doses administered. So, you may have some suggested actions for that, which might be to really kind of investigate the reasons, that you're seeing this at the district level, and provide some support, whether that's for recoding procedures or incentivizing accurate reporting versus high reporting, that sort of thing. So basically what we did was kind of map this out for each indicator to really help facilitate the interpretation and the action based on the trends that you are seeing in the data triangulation, in the triangulated data. Next slide. Great. So this graphic, and we'll dig into this graphic a bit more in the next few slides. This shows just the overall regular data triangulation process that we had laid out. And again, this was something that was done on a monthly basis. So let's take a look. Next slide. Great. Wonderful. So First, every month at that regional level, we would get the vaccine supply data from that system, the immunization program data from DHIS2, and they were sent to the immunization or EPI focal point in this activity that we were doing. The immunization focal point was kind of in charge of the entire activity, so they were managing this process from start to finish. Next. So then that immunization staff would import the data that they received into an Excel tool that we had developed to help merge the data and to facilitate the analysis. And then, what I see is kind of the most important part of this process is number 3, where the group actually meets. We made a very intentional effort to create a cross-departmental committee or working group that was looking at this data triangulation. So this was really the focal points for immunization, for supply chain, and for DHIS2 at that subnational level. So they would meet together, look at that data together, discuss, and then determine what actions are needed. Next slide. Great. So after the meeting, then the assigned staff would carry out those action items. Depending on the problem or the issue that was being seen in the data, the action items might have been different, right? So maybe some may have been kind of digging deeper into the data quality or the completeness of reporting, while another action item could have been conducting supportive supervision at the lower level. Right. So different actions were being taken. And, the idea here was really that the triangulation analysis was driving concrete actions that were happening at lower levels. So this really allowed managers to better pinpoint or prioritize their support in order to improve the management of services as well as the delivery of immunization services. Next slide. Yes, and then of course, lastly, just to say that this cycle would then repeat again the following month, and continue. Next. Great. So, we supported the rollout and the implementation of this monthly process in 2 subnational areas of Ethiopia. Um, and after several months of implementation, we documented what we were learning through some key informant interviews, as well as a review of the tool, the data, and the meeting minutes. So let's look at the findings. Next slide. Great, next slide. Thanks. So I'm just going to share some selected findings, and then we'll get into some implementation lessons. As was mentioned, this is written up in a journal article, so we can share the link to that. So some findings. So firstly, committee members were interacting with the data and with each other often, and they were examining the data holistically. So these were folks that maybe were not necessarily in meetings together all the time, but this was kind of fostering that sense of collaboration, and as well looking at that data together. Um, Another thing that came out strongly in interviews was that this idea of kind of simultaneously reviewing immunization coverage as well as the supply data was a somewhat new process, and there was really a recognition of a value add there. So there was a lot of value in kind of being able to look at that together. One of one of the implementation areas demonstrated rapid uptake of the tool and approach. So they were regularly using the tool for decision making. They were having consistent meetings, and over time, they were showing kind of increased mastery of the different processes, whether that was importing the data or kind of checking for errors, et cetera. The second area where we implemented this experienced a slower rollout. This was back in 2020. So in that area, they were experiencing they had some recurring conflict that was occurring, as well as some waves of COVID-19. And so these issues really affected the functionality and the performance of the region's immunization program as a whole. And then, of course, also caused a delay in the implementation of this particular activity. But this was kind of something that was affecting more broadly. And what we found was that reporting to these data systems had lapsed, particularly on the supply chain data side. So there was some steps taken to improve data availability prior to starting this triangulation process, just to make sure that we had enough data available to look at. So this was really an ongoing process. There was some work that was done up front, and then it was something that continued. And what we really did was encourage those subnational managers to just start with the data that they did have. And we'll talk more about that as we get to the end. Next slide. Great. So I'll just touch on some documented outcomes, just some couple of examples from this pilot activity. One was an increased number of outreach sites. So there was an analysis that was done, looking at they saw that they had low coverage in a certain town. However, they had perfectly adequate vaccine supply. So the action that was taken was that the immunization team met with the district and really tried to identify some of the issues of what was going on. And the outcome of that was that they were able to come to an agreement and launch additional outreach sites to be able to reach um, more folks in the community that were not as close to the health facility. Another documented outcome was a revising of a target population in another area. So they were seeing that there was some poor performance. So the action that was taken was a supportive supervision visit. And basically what happened was that they realized that some rezoning had happened, but they weren't accounting for this in their planning for immunization sessions and the rest. So they were able to revise their target population, adjust their micro plan, and move forward to take this into account. Next slide. Great. And I want to talk about some lessons learned, particularly because this was truly a learning activity. And there was so much during the course of implementation that we did learn that I think will be helpful. Next slide. So first, around the area of kind of establishing regular processes for using triangulated data in immunization. So first and foremost, triangulation can foster better coordination among health staff with different professional roles. I can't stress this enough. This is so important to be able to analyze data from different perspectives. You're getting folks into the same room, and then you're able to encourage that group problem solving, including with others that maybe you're not in meetings with every week. So it's so important. Second is the regular availability of data is important to fully leverage the benefits of triangulation. So it may seem obvious, but it is essential to ensure regular reporting of the data into those data systems, right? So what we really found is embarking on this triangulation process is that there still needed to be kind of parallel efforts to improve and sustain basic data availability and completeness, and to continue to prioritize that. And third, we found that subnational managers could use data triangulation to monitor issues at the district level. So um, we saw that in our implementation that it was really taken up as a kind of management tool, particularly at the regional level, so one level above district, um, and to really basically address problems that were happening at, for example, at the district level. And so it takes this kind of ongoing practice and support, but it really helped kind of pinpoint the support that needed to happen to districts. It was impossible for the regional office to do supportive supervision everywhere, for example. So they were really using this data triangulation data and process as a means to be able to prioritize where they needed to provide their support with limited resources. Next. Yes, and then a few lessons that we'd love to share on introducing tools and processes into health systems. The first, I think, will be familiar to all is designing with and for the users. So, from our perspective, data triangulation was kind of seen as this um, maybe difficult process or an ad hoc process. And what we really wanted to do was use this as a way that you could routinely be triangulating data to solve problems and to work towards performance improvement of the program overall. And to be able to make this a routine thing that we really had to kind of design it from co-design it with the users from the beginning to really see what was most important to them, what was that maybe the back end kind of work that needed to be done automatically, some of those pieces that I mentioned around having some pointers for the interpretation of certain indicators or even suggested actions to take based on data. So as much as we could kind of do that work ahead of time, that's what we ended up doing. Second is manage change, of course, and encourage new practices through frequent follow-up support. I think this goes for any kind of change process. Um, you have to be providing that regular mentorship and to really be troubleshooting technical issues that are during the rollout that come out, especially in the beginning, like they will happen. So being ready to provide that frequent follow-up support and then easing up as time goes on. Third is embedding implementation research into introduction processes. So when you're introducing tools into a system, we really felt that embedding the implementation research as we did was just so critical. It can provide so much valuable information on, what's working, what isn't, and then what do we need to do to adapt or improve the implementation and rollout. And fourth, last but definitely not least, was don't let the perfect be the enemy of the good. As I had mentioned before, regular reporting had lapsed just before rollout in one of our areas, and so this really negatively affected the data availability in this area. However, despite that limitation, we really encouraged the group to start analyzing the data that they had available, while at the same time working to improve overall data availability. So really the getting started with imperfect data that allowed the stakeholders to begin to work collaboratively and build those relationships to increase their comfort and capacity with analyzing triangulated data, and to begin taking action to address the problems at that district level. Next. Great. And just to finish up with way forward and recommendations, next slide. So I'm just sharing some selected recommendations. This was in the end a pilot kind of learning activity, and we do need more information, including at more advanced stages of implementation over a longer period, to kind of understand what regular data triangulation processes can look like. The approach that we took was just one approach. There's so many ways that you could think about introducing a regular data triangulation process. So, kind of understanding what different approaches could be and what might be most feasible. And then also more information on how data triangulation processes contribute to better programmatic decision making and better data quality. So really making that link between data triangulation and those kind of further outcomes that we're really looking for. And then finally, just some parting thoughts for anyone who may be kind of embarking on a data triangulation process or thinking about it, is one, to facilitate collaboration and decision making across teams and functions. So again, I can't restate how important that is to break down those silos. Make regular data routine, so promote that data triangulation as a regular process. Third, encourage attention to data availability, as we said, as well as to data quality. And then fourth, really focus on what are the concrete actions that we can take. We should not be doing data triangulation for triangulation's sake. It should be in service of solving some kind of programmatic problem or issue, or working towards better health outcomes. Next slide. Great. And with that, thank you so much. And I will be sure to share additional resources as well.
Thank you so much, Adriana. And thank you for that wonderful presentation. A lot of really great concrete recommendations, tips, tricks, very, very useful for all of us. So thank you so much. If you have questions based on Adriana's presentation, please feel free to put them in the question and answer box. We'll take some time at the end to answer and discuss. And with that, I would like to now turn things over to today's final presenter, Jean Dorville. He is a data manager with MRHIS in Haiti, and will be talking about his experience analyzing routine immunization data. Jean?
Merci, bonjour à tous et à toutes. Et je suis Dorville Jaounel, et gestionnaire de données de MRHIS Haïti. C'est un plaisir pour moi d'être avec vous et pour vous présenter la façon à nous d'analyser les données de vaccination de routine en Haïti à travers le projet MRHIS. Slide suivant, s'il vous plaît. Et le projet MRHIS est un projet de l'USAID en Haïti qui a pour objectif d'initier un soutien technique dans 5 départements afin d'éliminer le retard dans la saisie des données et d'améliorer la qualité des données sur la vaccination contre le COVID-19, et aussi de soutenir la mise en place du processus internationaux et nationaux de revue et d'utilisation de données avec une emphase sur les 5 départements du projet, à savoir, comme vous pouvez voir sur la carte, le Nord, le Nord-Est, le Nord-Ouest, la Tibonite et le Sud. Slide suivant. Suivant, s'il vous plaît. Merci. Maintenant, pour atteindre les objectifs, et le projet MRID a mis en place plusieurs activités, comme des missions de supervision et des ateliers de correction et de validation de données. Aussi, organisation des réunions de revue, d'analyse et d'interprétation de données. Cette activité se fait à plusieurs niveaux. Au niveau central, à travers l'UCNPV et l'UEP, qui sont deux organes déconcentrés du ministère, et au niveau départemental, à travers les directions sanitaires, et où on a des activités de façon hebdomadaire, comme les salles de situation et de monitoring, où on présente les données pour les analyser avec les cadres de chaque département. Aussi, il y avait des formations pour renforcer la capacité des cadres. Ces formations se portaient sur l'interprétation et l'analyse des données, mais toutes ces formations ont été réalisées de concert avec Chisou, qui est un partenaire de MRID Haïti. Et au cours de ces séances de formation, pas moins de 124 cadres des départements ont été formés. Mais aussi, il y avait des activités de validation de données sur DHIS2. Bien avant le projet MRID, le gouvernement utilisait déjà DHIS2 pour enregistrer les patients. Mais il y avait surtout beaucoup d'erreurs dans les enregistrements. Il y avait des écarts dans les saisies. Il y avait aussi beaucoup de données pendantes qui ne se sont pas encore saisies. Maintenant, avec l'arrivée du projet, MRID a procédé à des séances pour essayer de vérifier les données qui sont dans les sources, dans les registres, pour les valider, et ensuite procéder aux enregistrements des données qui ne sont pas vraiment encore été enregistrées sur le système. C'est pourquoi on a corrigé 51 114 dossiers et on a saisi sur le système DHIS 62 265 dossiers qui étaient pendants à travers les registres. Suivant. Maintenant, l'analyse de données, c'est tout un processus qui consiste à inspecter, nettoyer, transformer, modéliser les données pour découvrir des informations cachées dans un grand jeu de données qui pourraient permettre de prendre des décisions éclairées, des décisions opportunes, des décisions informées. Cela pourrait inclure à identifier les données significatives et établir les relations qui existent entre elles, utiliser des techniques statistiques pour comprendre les tendances et les modèles dans les données, et aussi essayer de visualiser les données pour une présentation claire et facile à comprendre. Vous pouvez avancer. Maintenant, en Haïti, on a essayé de schématiser le processus pour analyser les données de vaccination. Et ça se fait comment? Ce sont les données agrégées qui proviennent des différentes institutions sanitaires. Les rapports arrivent au niveau du département. Il y a un opérateur de saisie qui, avant de saisir les rapports sur le système DHIS2, vérifie la cohérence des données. Maintenant, après cette vérification, les données sont saisies sur le système DHIS2. Les rapports mensuels, ce sont des rapports consolidés. Ça, c'est l'étape 1. Maintenant, l'étape 2 consiste à valider les données au niveau institutionnel. Maintenant, on ne valide pas avant, c'est pour justement ne pas empêcher le département d'avoir une promptitude acceptable aux yeux du ministère. C'est pourquoi il suffit de vérifier la concordance des données, on saisit. Mais après la saisie, comme étape 2, les données sont validées avec les institutions ou les cadres du service statistique départemental se déplacent vers les institutions pour vérifier les données sources, c'est-à-dire à travers les registres, et comparé avec les rapports mensuels envoyés par les institutions. Et généralement, il y a toujours des petits écarts et ces écarts sont corrigés sur place. Les rapports mensuels sont corrigés car il y a une copie qui reste au niveau de l'institution et une copie qui est envoyée à la direction. On corrige les rapports qui se trouvent dans l'institution au niveau de l'étape 2, après la validation et la vérification des données à travers les registres. Maintenant, l'étape 3, il y a les données qui sont corrigées après la validation sur la plateforme DHIS2. C'est-à-dire lorsqu'on retourne après la validation, l'opérateur de saisie encore corrige les données sur DHIS2 qui ont été saisies préalablement pour analyse. Maintenant, les données sont saisies, les données sont vérifiées et corrigées. Maintenant, les données sont prêtes pour être exportées pour commencer l'analyse. Les données généralement sont exportées à travers DHIS2 sur Excel pour subir le premier traitement. C'est-à-dire les données sont traitées sur Excel, qui est l'étape 4. Maintenant, dans l'étape 5, les données sont chargées sur Power BI. C'est le logiciel qu'on utilise pour analyser les données. Maintenant, c'est dans Power BI que nous transformons les données s'il y a nécessité. Puis, on crée les visuels pour élaborer des rapports qui sont ensuite partagés sur Power BI Service ou de les exporter ensuite comme en fichier PDF ou en fichier PowerPoint pour les partager avec les différents responsables du programme pour essayer de voir, analyser les données pour prendre des décisions éclairées. Next. Maintenant, que cherchent vraiment les responsables du programme lorsqu'ils analysent les données? Généralement, c'est pour observer les tendances des couvertures vaccinales. C'est pour essayer de voir les couvertures vaccinales par commune, par zone ou par institution. C'est d'essayer d'examiner les taux d'abandon par institution, par commune. Et aussi, c'est de comparer les enfants 0-12, c'est-à-dire des enfants qui n'ont pas encore reçu le Penta 1, et les enfants sous-immunisés qui ne sont pas encore reçus le Penta 3. Et aussi évaluer la proportion des personnes qui sont complètement vaccinées. Mais dans tout ça, généralement, les responsables cherchent tout d'abord à analyser les zones qui ont un bon accès ou un mauvais accès et les zones qui ont une bonne ou une mauvaise utilisation du service de vaccination. Aussi, à travers les données, les responsables cherchent à définir des critères pour catégoriser les zones et aussi des critères pour prioriser des zones, pour savoir où effectuer des interventions pour accélérer la vaccination. Et pour faire cela, généralement, il y a 2 antigènes qui sont pris en compte. C'est le Penta 1 et le Penta 3 qui sont 2 antigènes traceurs qu'utilise le ministère de la Santé publique pour évaluer de façon générale tout le programme de vaccination en Haïti. Par exemple, pour déterminer si une zone a un bon accès ou un mauvais accès, généralement, ça se fait à travers la couverture vaccinale en Penta 1. Si une zone ou une localité a un taux de couverture vaccinale en Penta 1 inférieur à 50, on considère que cette zone a un très mauvais accès de services de vaccination. Par contre, si cette localité se situe entre 50 et 79%, on dit que cette localité a un mauvais accès au programme de vaccination. C'est-à-dire, cette localité se met en jaune. Mais si cette localité se situe, c'est-à-dire la couverture vaccinale en Penta 1 est supérieure à 80%, on dit que cette zone a un bon accès et cette zone se met en vert. Mais à part de la couverture en Penta 1, on considère aussi, ou bien on compare avec le taux d'abandon. Le taux d'abandon qui se calcule entre Penta 1 et Penta 3 pour essayer de voir s'il n'y a pas de perdition au cours de la route pendant que l'enfant prenne ses vaccins, s'il n'y a pas abandon au niveau du calendrier vaccinal. Maintenant, si le taux d'abandon est inférieur à 10%, on dit qu'il y a une bonne utilisation du service de la vaccination. Si le taux d'abandon est supérieur à 10%, on considère automatiquement qu'il y a une mauvaise utilisation du service de la vaccination. Maintenant, tout ça, c'est pour essayer de catégoriser les zones. Il y a des zones catégorie 1, on met en vert, c'est lorsque la couverture vaccinale en Penta 1 est supérieure à 80% et le taux d'abandon est inférieur à 10%. On dit que cette zone a un bon accès et une bonne utilisation, c'est-à-dire un grand nombre d'enfants commencent et terminent leur série de vaccination. Maintenant, cette zone se met en vert. Il y a aussi la catégorie 2 qui est en bleu, où lorsque la couverture Penta 1 est supérieure à 80% et le taux d'abandon est supérieur à 10%. On considère que cette zone a un bon accès et une mauvaise utilisation du service. C'est-à-dire, il y a un grand nombre d'enfants qui commencent leur série de vaccination, mais qui ne terminent pas leur séance de vaccination. Cela pourrait être dit maintenant, et lorsque les responsables analysent les données, ils pourraient dire que s'il y a un mauvais accueil, il y avait des ruptures de vaccins, il y a insuffisance de communication dans les calendriers vaccinaux, etc. C'est ce genre de choses que les responsables de programmes essaient de comprendre, recherchent lorsqu'ils analysent ces données. Il y a aussi une troisième catégorie qu'on met en jaune, c'est lorsque la couverture
Sorry, Sean,
Penta.
sorry, don't mean to interrupt. Dakota, could you advance the slides, please? There. Is this the right slide? Or you're on the next one?
Non, vous pouvez rester là où vous étiez, c'est bien.
Ah, okay.
On voit
All
ça
right.
après.
Thank you.
Oui, la catégorie 3 se met en jaune, c'est lorsque le Penta 1, la couverture Penta 1, est inférieur à 80%, mais le taux d'abandon est aussi inférieur à 10%. On considère que cette zone a un mauvais accès, mais a une bonne utilisation de services. Maintenant, comment on interprète cela? Peu d'enfants ont accès au service de vaccination, mais beaucoup parmi ces enfants qui ont accès acheminent leur vaccin. C'est-à-dire, il n'y a pas vraiment une déperdition malgré un mauvais accès. Cela pourrait être dû à une insuffisance de services de communication, rupture de stock, insuffisance de moyens de transport des parents, etc. Mais il y a aussi une quatrième catégorie qu'on met en rouge, et je pense que c'est là que les responsables de programme doivent mettre leurs priorités. C'est lorsque le Penta 1 est inférieur à 80% et le taux d'abandon est supérieur à 10%. Là, non seulement il y a un mauvais accès, mais aussi il y a une mauvaise utilisation du service de la vaccination. C'est-à-dire, peu d'enfants ont accès au service de vaccination et aussi très peu d'enfants terminent leur série de vaccination. Maintenant, cela pourrait être dû au manque de séances de vaccination, rupture de vaccins dans l'institution, insuffisance de moyens de transport des vaccinateurs, insuffisance dans la communication à travers la communauté, mauvais accueil, etc. Maintenant, vous pouvez avancer. J'ai demandé à Grace d'ajouter un slide, il paraît qu'elle a oublié. Maintenant, je voulais montrer dans l'image qui devrait suivre, après ce que je viens de dire, à travers les données, comment les responsables de programme priorisent les zones A, intervenir suivant les données observées, suivant la catégorie des zones. Il y a les zones rouges, il y a des zones jaunes, il y a des zones oranges, il y a des zones bleues. Les zones rouges sont hautement prioritaires, les zones jaunes sont très prioritaires, les zones oranges sont prioritaires, les zones bleues sont à priorité modérée et les zones en vert ne sont pas vraiment en priorité car il n'y a pas vraiment beaucoup d'enfants non vaccinés, beaucoup d'enfants dans 0 zone. Mais dans la catégorisation, il faut toujours prioriser les zones où il y a beaucoup plus d'enfants 0 dose, ou du moins beaucoup plus d'enfants non vaccinés. Maintenant, ça, c'est une image qui provient d'un outil d'analyse de données qui a été créé par MRHIS pour aider le gouvernement à analyser les données de vaccination anti-COVID-19. Et dans cette image, vous pouvez voir des indicateurs comme des SAVI, c'est-à-dire des effets secondaires après la vaccination. Il y a les vaccinés qu'on présente par commune. On présente aussi la tendance par année des personnes vaccinées et les personnes qui sont vaccinées par profession. Maintenant, tout ça pouvait être filtré par sexe à gauche, par département, par année, dépendamment de l'information qui est recherchée par le ou la responsable dans leur séance d'analyse et d'interprétation de données. Vous pouvez avancer. Ça, c'est un slide qui présente la couverture vaccinale par antigène. Vous pouvez voir la couverture des Penta 1 et Penta 3 surtout, qu'on considère pour essayer de catégoriser, pour essayer de définir et si une institution a un bon ou un mauvais accès, ou a une bonne ou une mauvaise utilisation qui se fait à travers les taux d'abandon. Maintenant, chaque commune, chaque département peut extraire ces informations pour les analyser et voir si leur zone a un bon ou une mauvaise utilisation de services de vaccination. C'est-à-dire l'outil est disponible et est exploitable par département et est aussi exploitable au niveau national. C'est-à-dire c'est cet outil qu'on utilise pour analyser les données à travers les données, les informations, les visuels qui sont disponibles sur ce tableau de bord qui est disponible sur Power BI Service. Vous pouvez avancer. Maintenant, on a appris beaucoup de leçons aussi lorsqu'on essaie d'analyser les données de vaccination. Généralement, il y a toujours les manques d'informations essentielles dans les enregistrements. Maintenant, il faut se débrouiller pour trouver les données, soit d'aller directement dans les institutions à travers le registre pour compléter les données manquantes. On a pu constater qu'il est essentiel d'investir dans la formation des professionnels de santé pour garantir une collecte de données complète. Mais aussi, généralement, les responsables de programmes n'utilisent pas vraiment l'analyse des données pour prendre des décisions éclairées. Maintenant, pour cela, il va falloir promouvoir l'utilisation des données dans la prise de décision et aussi assurer des formations sur l'utilisation et l'interprétation des données pour les responsables des programmes et aussi mettre à disposition des responsables des programmes des outils d'analyse et d'interprétation de données. Vous pouvez avancer. Maintenant, comme recommandation, comme je viens de dire, c'est de rendre disponibles des outils d'analyse, faire la promotion pour l'utilisation des données en vue de la prise des décisions opportunes et aussi assurer la formation des responsables de programmes sur l'utilisation et l'analyse des données. Et aussi, une chose qui est extrêmement importante, c'est d'introduire le registre de vaccination numérique dans le SISPEV, c'est-à-dire le système d'information du programme élargi de la vaccination pour faciliter la collecte des données et le suivi longitudinal des patients. C'est extrêmement important pour avoir des données non seulement disponibles en temps et en lieu, et des données plus ou moins complètes pour élargir l'analyse des données de la vaccination de routine. Vous pouvez avancer. Maintenant, comme impact de l'analyse des données sur la vaccination, on a pu constater qu'avec l'appui et l'application de Momentum en Haïti, nous pouvons mieux assurer la gestion de données de bonne qualité, capables de favoriser des analyses de données plus sûres. Cela aussi, l'application de MRHIS permet de cartographier les zones à faible et à fort taux de couverture vaccinale pour identifier les populations à risque pour mener des activités de sensibilisation. Permet aussi de trianguler les données de consommation de vaccins avec les zones de vaccins administrées. Car c'était un problème, un casse-tête tout avant. Généralement, on présente les nombres de personnes vaccinées, mais on ne pourrait pas vraiment essayer de regarder ça par rapport au nombre de vaccins administrés pour voir est-ce qu'il y a concordance ou pas. Maintenant, avec l'arrivée de MRHIS, cela a facilité de faire cette triangulation et je pense que cela apporte un plus dans l'analyse des données de vaccination en Haïti. Je m'arrête là, je pense que c'est tout. C'est la façon dont en Haïti qu'on procède pour analyser les données afin de pouvoir intervenir dans des zones à risque afin de prendre des décisions éclairées pour plus ou moins améliorer la qualité de service de vaccination en Haïti. Merci, c'était avec vous, Dorville Géronel, le gestionnaire de données de Momentum Haïti. À vous pour les questions, je suis disposé et disponible.
Thank you very much to all of our presenters for your very insightful and interesting presentations. We had a good amount of questions in the questions and answers, and many of them have been addressed. There has been a few responses and some really interesting discussion over in the Q&A. But for now, maybe I will direct a couple questions to some of our presenters. And my first question would be for Jean, which is, what suggestions or recommendations would you have for others who are working with local partners or with ministries in order to help them analyze routine data?
Bon, généralement, je pense que le premier conseil, c'est de s'approprier avec les responsables locaux pour les aider à comprendre que vous êtes là pour les aider. Parce que généralement, il y a toujours des réticences pour trouver les données, pour trouver les informations recherchées. Maintenant, si on montre qu'on est là pour aider, on est là pour faire avancer les choses avec eux, les gens pourraient mieux vous accompagner dans la démarche. Mais généralement, ils sont toujours réticents pour collaborer. Maintenant, c'est la communication, c'est l'observation et votre capacité à proposer surtout des choses qui pourraient les aider effectivement, qui pourraient plus ou moins vous aider à avancer dans votre travail.
Thank you so much. And maybe for one more question, I will direct to Adriana for a question about your presentation with the UI-FHS program, which focused mostly on program and supply data. Thinking back now, are there other types of data that you have considered or that you have used in your work that could be triangulated to help improve programming decisions?
Yeah, thanks, Zach. So I think another kind of triangulation that is common for immunization data, at least, is looking at surveillance data. So, for example, if you have cases of measles and looking at your coverage of measles in different areas. So I think that's often also quite common. I think regardless of what, what data you're choosing based on your question, I think some of the same principles apply around that process, right? So kind of that 4-step process that Emily went over in the beginning of, asking your key question, getting your data sources, getting context and analyzing, and then making an action plan. And that whole piece around the process is so important, regardless of whatever data you're looking at. Thanks.
Thanks, Adriana. I'm looking through and I don't see too many more questions. I think we are coming up on time, so I will hand it back over to you, Emily, to wrap us up.
Great. Thank you so much, Zach. So let's see. I want to say, next slide, please. Advance one more slide. For the wonderful presentations today, to Adriana, to Dorville. Lots of great questions, lots of great discussion. I saw a lot of some comments in the Q&A about interpretation and use of data and how important that is. And I think that's a great segue. Our next session next week will focus on data interpretation and use and how to support your local teams to use your data and interpret it well. We'll have some presentations from Momentum Country and Global Leadership. So that should be a really interesting presentation next week. So I invite you to attend. You can register using the same link as you did for this session. And yes, just finally, next slide, a thank you to our presenters, our interpreters, everyone who is helping to support the webinar today. We appreciate your attendance and your engagement. So thank you all and hope to see you all again next week.